Health Academy, learning solutions for health professionals.
Hello. It's so nice to have you here. And me and Becky decided this was totally accidental, but we are wearing the same thing today by accident. We're kindred spirits. Um, anyway, without further ado, let's get cracking. So, welcome everybody. Thank you so much for giving up your lunch, or maybe you're eating it now, to join us for this lunchtime session. If you've been to a few of them already, you'll kind of know the format by now. We either interview somebody prominent, like Becky here today, or we do a short session just recapping some things. And today is one of the interview sessions. We often get told it's too short, but we try and make it short so that you can fit it into lunchtime. And I think if we made it longer, we'd also get complaints the other way. So we try our best. We've got 45 minutes. We will cram as much as we possibly can into this session for you. So we've got the lovely Becky here. I'm so honoured to be interviewing Becky today. She introduced me to the world of travel health all them years ago and trained me up, and she's just wonderful. Love her to bits. And I'm sure from looking at the names in the chat, I'm pretty sure there's a lot of people here who also know Becky and were trained by her. And so, anyway, what are we going to look at today? We're going to look at some key themes in travel health. So Becky's going to tell us a bit about her journey, first of all, into travel health, what got her into it. We're also going to look at emerging travel health trends and things like that. We're going to look at some hot topics and misconceptions. There's quite a lot around travel health. And we're also going to look at some confidence boosting tips as well. We've basically, we always invite pre-submitted questions and we tailor our questions around that. So thank you if you've submitted a question in advance. We are hoping to be able to get to some questions in the chat box if you think of any during the session. We can't guarantee we'll get to them, but we'll try our best. What we were thinking is, after looking at the waiting room names, we thought, well, actually, there's a lot of experienced travel health specialists in this group. So if you spot a question in the chat that you think you can answer confidently with reference to evidence, please feel free to help us out so we can cram as much in as possible today. Anyway, without further ado, let's have a look at Becky and focus on her. So let's start with what first drew you into this fabulous field of travel health, Becky? Tell us
Oh,
all about
well, hello. I was going to say good morning, but or afternoon. Well, thanks for having me. I don't know if you should feel honoured, but I'm honoured to be invited. Thank you.
it.
Um, so, what got me into travel health? Well, I all I ever wanted to do as a kid was travel. That was my only ever want. And then I also wanted to be a nurse. So I first went off travelling soon as I qualified as a nurse, and travel health then, where I went to my local clinic, you went into your practice, into your GP practice, they gave you a Hep A typhoid vaccine and off you went. And that was it. There was no discussion. It was just an injection and you went off bulletproof. And on that first trip, I managed to get amoebic dysentery within 8 hours of arriving in India, and was stuck in a room for 10 days. And then throughout the trip, I got giardia, tropical ulcer, suspected dengue. So all of this, and so all of those could have been really avoidable if I'd known much about it. Anyway, came back to the UK, found a job advertised at Nomad in a private travel clinic. And back then, 26 years ago, travel clinics weren't really a thing. I'd never heard of such a thing. But got a job at Nomad, thinking, brilliant, I can combine nursing and travel health and try and stop people being as stupid as me. And that's where I started at Nomad, working in really busy travel clinics, and then went on to manage a few of the clinics, was involved in their training, worked at student health at Bristol University, setting up their travel clinic. And my roles just evolved as it's gone on, really. But that's what
Yeah,
got me
this
into it. Stupidity.
stupidity. I learned the same way, doing the wrong things abroad, learning the hard
Yeah.
way.
And I still am. I'm still, even when I travel now, I know what I shouldn't do, but it's a bit more measured now, though, I think.
Yeah,
I
yeah.
know
I
what I'm
remember going
doing
on my
wrong.
honeymoon and ordering a mojito and having ice in my drink, thinking I tell people all the time not to do ice in the, we
Picking the ice out.
we got to practice what we preach. It's quite hard sometimes, isn't it?
Yeah.
Oh, so you told us a bit about how your role evolved as well, which is really interesting to hear. You've done so many things, haven't you? And it's
Yeah, I've been really
so
lucky.
many things.
Yeah.
So what continues to inspire you about this area of practice?
Well, it changes constantly. When I first started, I thought it was just limited to vaccines and malaria and learning about vaccines and some preventative measures. But, as time goes on, we know that, I'm writing travel health updates. We're doing travel health updates. And before every update we're delivering every couple of months, there's things that are changing all the time. So it's an ever evolving specialism, I think. So I think that's what inspires. I'm always learning.
Yeah, you're
Um,
never bored in travel health, are you? There's always
no,
something else to
no,
learn.
no. And
Yeah.
I love hearing about people's trips, which are always changing and getting more complicated, I think, these days.
Absolutely.
Yeah,
It's changed so much, hasn't it, over the years?
yeah.
So I think some of what you've said already is suits my next question. But if maybe we can expand on that a little bit. But the next question, of course, is for nurses and pharmacists as well, considering specialising. And I know there's more pharmacists than ever getting involved now. What advice would you give to specialise in?
Well, I think what sort of really helped me was doing, a course. So I did the diploma in travel medicine in 2006. God, blimey, 20 years ago. So, and that really sort of springboarded things. Although I had lots of experience, and I think experience is really important dealing with travellers. But then doing some sort of formal course, and there's quite a few out there now. You can do the professional development certificate in travel medicine or the postgrad diploma in travel health. Those are offered by the Royal Society of Physicians and Surgeons in Glasgow. It's
A
always a
mouthful,
mouthful.
that one, isn't it?
Yeah. Um, for those that want to do things more part-time, the Liverpool School of Tropical Medicine, they do a course that they've developed with NAFNAC. That's a 9-month online course as well. So there's lots of courses out there that you can fit in with what you're doing. And I think they really, really help you understand the advice you're giving and give you evidence-based background really to what you're doing.
Yeah, you can go so much further with this, can't you? It's so much
Yeah,
further.
yeah, absolutely. Yeah.
Yeah. Okay, well, that brings us on to the next section of the questioning. Thank you so far.
Okay.
So, emerging risks and global health trends is the next section. We want to look at what's changing in 2026 in relation to vaccines, behaviors, infectious diseases, and stuff. So, let's start with what new or re-emerging diseases should clinicians be aware of this year?
I don't think any of us can escape sort of the rise in insect-borne infections. We're seeing huge increases in, well, we've seen increases in Zika, but chikungunya, dengue, I think anyone who's working in travel health, that's not surprising. And with climate change, we're seeing shifts in areas as well. So I think we're going to see even more of insect-borne infections. Oropouche in the last sort of 18 months, we've seen, which is spread predominantly by midges in the Amazon basin. Although that's not a new infection, we're suddenly seeing cases. And I think last thing I read, that's the second leading most cause of insect-borne infections now, or fevers caused by insect-borne infections in Brazil, certainly. So I think we're seeing an increase in insect-borne infections. I think maybe sexually transmitted infections as well. We've got, increases in the UK, in our UK population, and with increases in travellers, we might see increased numbers there. The surveillance and response systems for things like STIs and HIV in some regions globally was disrupted during COVID, and I think that's leading to maybe some resurgence and harder to beat infections like antibiotic resistant gonorrhea.
I think the antibiotic resistance is a big problem, isn't
Oh
it?
God,
Vitamin
yeah,
C as
yeah,
well. And yeah, I'm wondering about tick-borne encephalitis as well, with that,
yeah,
increase.
yeah. But we've had the cases reported in the UK, didn't we?
Yeah.
Not too many. What's that?
Yeah, and
A
I think the
couple of
last
years ago.
JCVI notes were talking about it
Yeah.
being an occupational health recommendation, possibly. Yeah, interesting. Lots of stuff going on, keeping us on our toes. So, how are changing travel patterns influencing the risk profiles as well? Because there's changes there too, isn't there? With the different.
Yeah, I think people's trips are changing when when you're reading reports and looking at surveys. I think people tend to go for longer. I think people are being more daring than we used to. We're seeing a lot more remote travel, rural travel, off the beaten track destinations, and even on a personal level, using AI is transforming, I think, people's trips. I mean, I went to Indonesia last year with our four teen girls and did all the research through AI and managed to get into really remote areas that I never would have put ourselves and involved in sacrifices and local ceremonies and such like, which we never would have found without being able to research things. So I think things are changing. I've been reading recent reports of increase in people going on wellness retreats, places where people completely cut off from civilization, which can cause risks in itself. More VFR travel as well. So people going into more remote areas really with basic facilities. Um, I think we're seeing changes due to climate change is changing disease geography. So, for example, mosquito-borne diseases are shifting. We get locally endemic, locally acquired dengue, chikungunya in France, Italy, Spain, and they think the UK will be a good reservoir for dengue and chikungunya in the future. And they actually found albopictus mosquitoes in the UK, according to BBC actually last year. So we're seeing climate change changing where things are happening. Climate change is causing extreme weather. We're seeing a lot of flooding and extreme weather patterns, so forest fires. But with flooding, we're seeing increases potentially of diseases like cholera, leptospirosis, hepatitis A, food and waterborne infections. Um, Heat waves put travellers at risk. If we think of our Hajj travellers, we've had deaths in Hajj travellers due to heat
Yes.
exhaustion. I
Yeah.
think temperatures get up to the
50.
late 40s, don't they?
Yeah.
Yeah,
Oh,
really, really extreme weather conditions people are being exposed to. Um, so all of those will change people's risks. Um, and I think we're seeing a shift in travellers a bit more as well. I don't know if you're seeing it, but certainly a lot more older travellers because people are fitter into their older age. I think it's easier to travel now. So we see a lot of older travellers who may have comorbidities and maybe, their immunoessence, so their vaccines aren't working as well. We have more travellers with chronic disease travelling, compromised travellers going to areas that high risk of infections and complications from those infections. So I think there's lots of changes happening in
so much. Yeah.
travel. Yeah,
Post-pandemic as well, you got people who are itching to get out for those horrible few years, and then now they're doing the trips they planned to do, that they were cancelled. And then you've got people who are working from abroad as well, like they've worked
yeah,
out they can work virtually, so they're going
yeah.
and sitting on a
Digital
beach.
nomads.
I'm hoping I get to that stage where I can teach my courses from a
Oh,
beach.
that's the dream, isn't it?
Yeah, that's the dream.
From a beach.
Yeah.
All in
So
the name of research, that's what I say as well for travel health.
research, yes, job related, absolutely. Yeah. Yeah, so you've outlined loads of things there, but what about the other side of it in terms of like vaccine recommendations? Are there any updates to vaccine recommendations or PGDs and things that we should keep our eye on as well in relation to the prevention side of it?
Well, I think the one that most people would be aware of is chikungunya. We're waiting for the Green Book to be published, the chapter in the Green Book to be published. We've already got vaccine recommendations, which is brilliant on NAFNAC. Other changes we may see in the latest JCVI minutes from their last meeting. I was having a read through there, and they were discussing about the consideration about removing an egg allergy contraindication with Rabipur, for
Mm.
example, because the levels of albumin in Rabipur are so low that actually we should be able to consider that in pre-exposure. We can't make any changes yet because it's not being put into the Green Book, but
Mm.
it's things that they're discussing. And interestingly, they were also looking at egg allergy with stamaril, yellow fever, because we can give the live flu vaccine with levels of albumin in
Mm.
at very low levels. And actually the levels in stamaril, whilst are slightly more than in the live flu vaccine, they are still quite low. So they're actually considering looking, and they're putting some studies into looking whether they can remove the absolute contraindication to yellow fever with egg allergy.
Mm. Yeah.
So
Mm.
because apparently yellow fever is given abroad in endemic areas to lots of children with egg allergies and anaphylactic allergies, and
Okay.
there's not been evidence that it can cause anaphylaxis. So it's something that we may see in the future. They're looking into
Mm.
that. Um, Rabies, we know that the SPCs for the rabies vaccines in the UK, so certainly Vera-Rab and Rabipur have been updated to a two-dose schedule,
Mm.
0
Yeah.
and 7 days.
A lot of questions
Which,
about that on courses, quite a lot, right?
yeah,
You'd done it in the Green Book as well, yeah.
and I think I've heard, I think a couple of private travel clinics offer that as their primary course. So the two-dose schedule is what's recommended by WHO.
Mm.
But we in the UK, we still do our three-dose schedule. But whether that will change, I don't know. That that may do. We know that I believe the WHO do the two-dose because they're giving advice for all the countries around the world where vaccine isn't as easy to obtain. So it's to give that consideration. In the UK, three is still the best. But if people can't, then we would obviously say, well, two is better than none. One is better than none.
Yeah, I think it
Um,
relates to the post-exposure too, doesn't it? How we would treat
yeah,
a partially vaccinated person. So that
yeah,
would have to change in conjunction to be recognized as a full schedule.
yeah,
So
absolutely. It'd be a major shift in
yeah,
all of
yeah,
it, wouldn't it?
yeah,
Yeah.
it would affect a lot of things.
Yeah, so we might see that.
Mm.
Um, I mean, I don't know whether Mpox vaccine for travellers might be something on the horizon. It's not something I've heard necessarily, but where we're seeing this latest Clad 1 outbreak, now it's in Europe as well, isn't it? We're seeing outbreaks occurring across the world. It's not an international emergency of concern anymore, but we are seeing lots of outbreaks. The vaccine isn't recommended for travellers routinely at the moment, is it? Unless they're humanitarian aid workers going into risk areas. So whether we might see that shift, I mean, I suppose with the Mpox vaccine, it is something that we can always check with our travellers. It's a really good moment to check people's sexual gender, whether we can actually, whether they fall in the inclusion to have it at a sexual health clinic if they're the GBSM group, because then they could have it routinely,
Mm.
and we can refer them. But at the moment, it's not there for travellers.
Mm. I think
Um,
some countries have put travel recommendations in for Mpox, I believe, which is interesting. Probably
yeah,
something to review.
another one to add. Yeah.
But I like the point about, making sure we signpost as well to areas where we might not give the vaccines. That's a really,
Yeah, absolutely. And that's the brilliant thing with the travel health consult, isn't it? It's a really good opportunity to catch up on everything, isn't it?
yes,
Anything someone might actually attend for a travel vaccine, but they haven't been up to date with any of their routine ones, so it
absolutely.
is a
And
good
certificates bring
opportunity.
people in as well, don't they? Certificate requirements who might not, put a priority on vaccination. Uh,
Yeah, 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 absolutely.
mm.
Yeah. I've just seen there was a question. that
From
came in just
Carol.
while I talked about rabies. It said any booster for rabies following a full course. Well, the UK recommendations are if you have your full course of 3, if you go to an area of high risk after a year, we give a one-off booster. That's the recommendation at the moment if you have the standard course. And then otherwise it would just be post-exposure. Yeah.
Mm. A lot of that as well is quite gets quite complicated, that doesn't it? When you've got somebody in a consultation who could have a rabies booster, might want to start a course of Japanese encephalitis. Where do they put the budget? Often there's budgetary considerations with that one too,
Yeah.
isn't there? And
I think
might,
that's the
yeah,
biggest dilemma. I think with a lot of travellers, if it was all free, they'd probably take
yeah,
most of the vaccines, wouldn't they? But it is a
it's a
costly venture.
journey. Yeah,
Yeah,
especially when you've got a big family going. You know,
yeah.
um,
Oh well, I had to do it with mine. Yeah, 4
yes,
teenage
yeah,
girls. It was
yeah,
very expensive trying
yeah,
to prioritize everything. Yeah,
yeah.
yeah, yeah.
Um, Was there anything else there? Sorry, I cut you off a little bit there. I do apologize. Get too excited about this topic.
Yeah. No, I don't think so. No, I don't think so there.
Oh,
I think, yeah, so we're talking about updates. Yeah, those are the ones that sort of sprung to mind, really. I
yeah,
mean, whenever we do a travel health update course, obviously that's what we're focusing on is what's happening at the moment, what we're expecting to change in the immediate future. So it's always worth going on the full update course or update day.
absolutely. Wish we
Oh,
could say it all today, but there's no chances there.
no.
Melina's just asked or mentioned something as well about reading somewhere that we need to issue polio certificates for some Asian countries, and I mean I guess for that one it's keeping an eye on NAFNAC recommendations there for that. So obviously we do polio certificates for a place like Afghanistan, and it changes every few months really, and they.
Yeah, so the Emergency Committee for Polio, International Health, they meet every 3 months.
Mm,
So the last one was November, so they'll be due December, January, so they'll be due again in February. They meet and it changes every time, whether countries are endemic or whether they're exporting polio, and their recommendations will change. So just use NAFNAC, and it's just about always remembering to read the certificate requirements and the polio
mm,
vaccine recommendations, reading
yeah.
both, and it should all be there.
Yeah, most complex stuff like that can be solved by just reading it dead careful, like with
Yeah,
yellow fever as well.
yeah,
Yeah,
absolutely.
top
Yes.
notch, definitely. And okay, so you've mentioned already about the idea we do travel health updates, and the recommendation is to try and do them as regularly as you can, and that kind of thing. But how else can those working in travel health stay up to date with all this fast-moving guidance? What's your top tips?
Well, I think it's probably an obvious one, really. I mean, NASNAC is
Yeah.
brilliant.
Yeah.
Every day, their latest news section is or every few days, they will publish any sort of latest updates there. We used to have Travax, but that's been shut down now. Sadly, that's been discontinued for now. But with NASNAC, you can also sign up for their newsletter on their homepage. So then every week, into your inbox becomes a summary of all the latest news. So if you haven't got time to go onto the website before every session, at least you can get that as one sort of newsletter.
Mm,
Um, and I think for the UK, that's the most reliable resource really for fast moving guidance. You can
yeah.
sign up to Green Book updates, you can go onto their page, vaccine updates. So the vaccine update by .gov, you can sign up to receive where you'll get updates or anything that's happened. But recently, NAFMAC have been publishing any travel health updates with Green Book as well, any
I
changes
noticed
there
that.
as well. So I think that's my most reliable.
Yeah.
Um, yeah, and anything
Absolutely.
significant.
One
And
of the
obviously your
factors.
malaria guidelines as well, that
Yeah.
check for updates regularly there as well.
That's also a gov.uk site, isn't it? That you can click
Yeah.
email alerts for as well. All of the gov.uk sites have an email alert button. It's well worth looking.
Yeah, and that's what I've done. I've just signed up
Yeah.
to all of them, and then it just comes into my inbox so that you get all these updates. And even the Foreign Office, you can sign up.
Mm.
And that has some really interesting updates. So things like the methanol poisoning, when we had the warnings about that, that was actually highlighted in Bali about a year before we saw these deaths in Laos. So it was something that was on the radar. So anything that's significant that's changed on pages comes up under the country pages, under the Foreign Office as well. So
Yeah.
that's quite a useful one to
Yeah,
do.
gosh, so many ways. The childhood schedule has sent a lot of emails. This has been about 16 in one day, I think was the maximum I got once.
Yeah.
Nightmare. I know many of the people in this group will be in busy general practice and have had all of those emails too. And of course, for updating Health Academy, do a travel health update. Got to put a little plug in there. Why not?
Absolutely.
Let's move on to the next topic, which is hot topics and common misconceptions. So, what misconceptions do you most often hear from travellers or from clinicians?
I think a question that comes up, or I don't know if it's a misconception, but a query and a question that comes up on most travel health update courses is around hepatitis A,
Mm.
whether we restart courses and any vaccines really. You know, if somebody had their first Hep B 3 years ago, do we restart today? With hepatitis A, I had the first one age 7, and now the child is age 19. Do I need to restart? And we know, according to the Green Book, that we never restart courses for all injectable vaccines. The only exception to those rules are oral vaccines. So if we're thinking about cholera or Vivativ, the typhoid oral vaccines as well, or Vaxchora, because they're oral vaccines, you don't maintain such good immune memory when it's taken through the gut. So with those, we would always stick to the schedules, but with injectable vaccines, just carry on where you left off. So if
Yeah,
someone had their first rabies 3 years ago, today's their second rabies.
yeah.
We just carry on.
Yeah,
Yeah.
I would argue probably the only injectable you'd perhaps start again if it's interrupted would be if MMR was given below 12 months as well. That
Yes.
situation.
Yes, absolutely. If you gave that early from, say, 6 months, which we can for high-risk travellers, so we've got a baby going to an endemic country or there's an outbreak happening, we can absolutely give the MMR from 6 months, then ignore that dose and then carry on. Yeah.
Yeah,
And I suppose we would also do the same. I suppose the only other rule is when you're giving things like yellow fever and MMR, if you have to give them within a month, because
yeah,
we give them a month apart. If you gave them closer together, then we would ignore those and we might consider revaccinating as well.
yeah,
But with courses, generally, you just carry on where you left off, which makes it a lot easier. So
absolutely. Every dose.
Carol's just asked, with junior Hep A, is that 25 years or lifelong, or do they need adult course? So it's the same for junior or adult. Your first dose, depending on the vaccine you give, will protect for anything between up to sort of 3 to 5 years, but we say a year. So we recommend someone comes back 6 to 12 months later, that second dose will last 25 years. Now, if you give that second dose 10 years after the first, that second dose will last 25 years. And then at the moment, we would boost again at 25 years for another 25. I think that will change at some
Mm.
point in the future, but at the moment we do 25 years, not lifelong at the moment.
Yeah. And I think as well, making sure it was an age appropriate. If someone was given the Hep A at the right age with the right vaccine, because we did have a few years ago where the adults were being given junior doses when
Oh,
there was all
yeah.
that chaos and the temporary guidance came out. So they might be slightly different for those. If you had a junior Hep A when you were 25, that would be different. But yeah,
Yeah.
she seems happy with that answer there
Great.
from the chat box. Oh, we've got another question here about schedule. We always get lots of questions about scheduling, don't we, on updates. Christina's asking, when do you need the second and third dose? Let's say Hep B if the first dose is many years back. I think you've kind of addressed that all.
Yeah, so just consider that first dose was your first dose of the course. So your second, it would depend what schedule you're giving with your Hep B, for example. So say you were doing an accelerated schedule using Engerix-B, So 0721, which we can use with Engerix-B. Then today, the second dose will be day 7, and then your third dose will be in 2 weeks' time. Or if you were doing the 012 schedule, today would be your month 1, and then your second one in a month's time. So just that was your first dose. That's how
Yeah.
you would include it.
So
Yeah.
those intervals on the 017 is minimum intervals, aren't they? That's
Yeah.
the thing.
Yeah,
Yeah.
it's always fine to extend. Just don't shorten courses. That's the golden rule, really.
Yes.
Yeah.
So what is your approach to people who decline recommended vaccines or products? I suppose we could add to that in travel health as well. What's your advice there?
Um, I think it's try and understand why they're declining it would be my first approach. Is it because of costs, or is it because of any myths or misconceptions they have around the efficacy of the vaccine, or any concerns around side effects of the vaccine? So try and understand why they're declining, and then maybe you can signpost them and give them information to support giving the vaccine.
Mm.
If they continue to decline, well, then it's making sure they understand the impact of the disease, how they catch it, the symptoms, the treatment, preventative methods, and you would really focus on prevention methods. I mean, vaccines, although they're very important for travel health, vaccines only protect against a very small part of disease risks. And even, if we think about typhoid vaccine, it doesn't cover all types of typhoid, it doesn't cover against paratyphoid. So we should always be giving advice on prevention methods as well as the vaccine anyway. But I suppose you would just focus more on it if they decline the vaccine.
Yeah.
And really importantly, document as much what you have given as what you haven't given, because it's
Mm.
really, really important, that you've got that for your own accountability, really, that you have
Yeah.
discussed it and recommended it.
I don't think we discuss informed dissent as much as we do informed consent. We perhaps
No,
do need to put more focus on that. I
yeah.
discovered a really good website in recent years. I'm going to put it in the chat box for people. Jitsu Vax. If you've not heard of this, it's very good for challenging misconceptions and things as well, making sure that when people do
Okay.
decline, they decline because they had the facts to decline on, and of course people are absolutely entitled to decline. I've just there's still loads of questions coming in
Oh,
about
look at you.
about scheduling. We perhaps need to do the next one just on scheduling, perhaps.
Yeah.
I don't know if any of those are quick answers. I'm just conscious of the time, but we are moving on to the third section shortly. Did you want to address any of those quickly?
Um,
We've got the Francis was
right.
asking.
So Jamie said that the reps for rabies vaccines say EMC is stating only 2 doses like the schedule in other countries. What is your understanding? And I think at the moment we have to follow JCVI guidance, which is 3 doses.
And
So
they
although
can't
it's
advise out of the
licensed to give,
license.
sorry,
They can't necessarily advise out of the license either. It's
no, no.
difficult.
So it's not 2, it's still better than not.
Yeah.
So, and it is internationally recognized. I mean, how I approach it is I would always advise 3, because that's what our PGDs would recommend and what JCVI recommend. But if people can't afford 3, can't fit in 3, can't do 3, then have 2. You'd be considered partially vaccinated in the UK. All it would do is change your post-exposure requirements. So it would change the number of vaccines we would give after if we gave 2 before or 3 after. That's the main consideration, really.
Yeah. And then very quickly, Francis has asked her if an adult had a junior Hep A vaccine years ago when there was a shortage of the adult strength, would you discount and start again? I mean, I probably would. But what's your thoughts
Yeah,
on
there
that?
was, well, when we had the shortage and we were giving paediatric Hep A, we were fully expecting guidance to come out afterwards to suggest maybe that we do ignore it and carry on, but that guidance never came. So my understanding is that we would consider them vaccinated. I think the Hep A vaccine is so effective, then the ELISA levels in it are quite high, that they considered it would give an adequate response. Because with no, I mean, I'm not giving that as a formal recommendation, but there was the JCVI didn't follow up after the outbreak telling people to be revaccinated. So there was no formal guidance to ignore that dose.
Yeah, it's a
Um,
difficult one because it's
yeah,
a lower dose, but like I say, very immunogenic vaccine. Um, but again, no advice.
I can't give you formal advice because there
But
wasn't any.
yeah,
There
I
isn't.
think yeah,
I think if you had someone in a high risk situation and there was any doubt going into a high, there being a VFR traveller going away for a few months, then you can never over vaccinate.
mm,
So, if you're ever concerned, it's better to vaccinate than not. But there isn't any formal guidance that I know of out there on that situation.
I think I'd probably go down that route if you can't over vaccinate to
Yeah.
save all the worries about it.
Yeah.
Um, right, I've lost what I'm up to now. Oh, practical confidence boosters. That's what we're going to talk about just to finish. Gosh, we've fit so much in already. We've only got 10 minutes left.
Okay.
So let's go quick. Thank you for all your questions. Right, so what strategies help build confidence in those who are newer to travel health?
I think experience. So, as in maybe sit in on some experienced colleagues that can help. And I think when you sit in on people, first of all, it can be a bit overwhelming, all the information, but you'll notice people that are experienced, they have structure with their consultations. And once you learn some structure, that can really help. Um, Using risk assessment forms, the RCN recommends use of risk assessment form, as does the Faculty of Travel Health. There's example ones on NASNAC, and I think most practices do use them now. So use that to help with your structure, and that gives you a format. Use NAFNAC. NAFNAC has everything you need to know, really. A lot of people just jump to the country information pages, but there's so much more there. There's fact sheets on all the different diseases, and they have them in brief as well as in full. If you have a VFR traveller, it will give you advice on what things you need to consider, or a diabetic traveller. So everything is there, and it also has in their fact sheets clinic resources section, which will tell you different resources you can use, training days. There's lots of free training. You can go on. NAFNAC do regular webinars, and they've got quite a few on their website at the moment. The BGTHA, which is the British Travel Health Association, if you join for, I think it's £30 a year, you go to their free conference every year, and they send out a journal. There's lots of things you can do, really. Ignite, when we all started, it was about getting a risk assessment form and practicing, learn the basics, but ultimately do a course. Health Academy do a foundation, the fundamentals of travel health, which you can do face to face or in your own time, and it really is advised that you do at least a 2-day course before you even start, just to give you that foundation of knowledge before, and then practicing. I don't know if there's anything I've missed,
No, I think
Ems,
you've
that
said
you
some really
think.
good advice. Someone's put in the chat box, Mariah's put, don't forget Jane Cudini as
And
well.
don't forget Jane
Great Jane
Cudini, of
Cudini.
course.
How could we forget Jane? Technically she's a rival training company, but yes,
Yeah.
absolutely. Jane as well. Um, Okay, so you think you've mentioned some of these already, but your go-to resources for professional networks for ongoing learning, you've already mentioned a few, haven't you? BGTHA, the Royal College. Is there anything else you want to select?
Yeah, so it's the Faculty of Travel Medicine, BGTHA, NASNAC. I'm trying to think other resources. On Facebook, it's not really a profession. We've got the Travel Health for
Mm.
professional. I'm trying to think I can't remember the name of it, but there's a group and there's about 5,000 members, but for travel health specialists and people working in travel health, and that can be really useful to see what's going on. Going to conferences is a brilliant way of learning new things that you might not even have considered, seeing how other countries approach travel health as well. So there's the NECTEM conference in Belfast in June this year, which I'm hoping to go to. But the Faculty of Travel Medicine do a conference, the BGTHA do as well. So there's lots for ongoing learning.
Absolutely. I'm
Yeah.
wondering if perhaps someone in the background for Health Academy can put the Facebook group link in the chat for
Yes, please.
everybody.
And I went completely blank on the name of it then.
It's a travel health for health professionals.
I've got you as well.
Let's try and find the link for that. And,
Yeah.
uh, but yeah, it's really good, isn't it? Like, whilst we shouldn't probably recommend Facebook as a professional source, the people on it are giving you professional sources. That's the key thing. And there's
Yeah.
loads of us on there, isn't there? Travel health geeks willing to help you out, waiting for your question.
Yeah.
So,
And you learn lots of new bits on there. People share articles and um
yeah.
yeah, things that are going on.
Yeah.
Yes.
Oh, Michelle's popped it in the chat for everybody there. Yeah, it's
Mm.
a good one. And if any of you today wanted a bit more answers to questions, again, you could pose them on there if you like. We'll keep an eye out for you admitting yourself. So, gosh, we're at 10 past already, which gives us 5 minutes just to address some more questions and close the session. So, pre-submitted questions. We had one from Gillian, and I think this is kind of a legal and professional question, really. Part of a practice nurse team, very experienced, but no recent travel updates. She has all the relevant PGDs signed. The question is, can her colleagues who've completed and documented the consultation with the patient then leave her to actually give the vaccines that they have suggested? It's a big
Okay. So
question.
this is something that's really common, it seems. It's a
Mm,
question we
yeah.
get asked quite, I expect you do as well, Alice, certainly on a lot of the travel health update courses.
Mhm.
I think since the GP contract shifted that GPs have to give NHS vaccines. It's caused a shift in how people do it because previously people may have opted out, but now everybody has to give the vaccines. Now, the CQC actually say, and everyone will be registered under the CQC, certainly for practice nurses. Pharmacies won't be under CQC, but they state that a pre-travel risk assessment must be performed by the healthcare professional giving the travel vaccine under a PGD.
Mm.
So if you haven't got experience, even if you're working under PG, you cannot give the vaccine or you shouldn't be giving the vaccine if you haven't done the risk assessment. Um, and there's lots of resources really to reinforce that. The national minimum standards again say those that give travel vaccines should have training in travel health. It's not just about giving the vaccine, you'd need to be competent. If you're delivering under a PGD, then in order to be competent in line with PGD competency, you actually need to understand what you're administering, why you're giving it, the risk, benefit, contraindications, and precautions. So if you're a registered nurse, I'd be really, really nervous and you shouldn't be giving it under a PGD. You could do it under a PSD, but again, even if you're giving a vaccine under a PSD, you still want to understand why you're giving that vaccine. Make sure your patient understands, because at the end of the day, you're accountable, when you give that. But if that's the only process, then a PSD is going to give you a better framework than a PGD. But really, you need to do your risk assessment yourself, or you're not covered.
Yeah, the
Yeah.
same question comes up all the time. And I think one's come up in the chat box about nursing associates, pharmacy technicians, who often, well, will only have the PSD as an option here. And that can add a bit of logistical trickiness to it. It's not impossible, but it does add a few more things. And we also got asked about recommending the chikungunya vaccine as
Okay.
well, but when to recommend it. So they give an example of a fit and well 35-year-old week in India. It's an outbreak area. Should we be recommending? Perhaps you can, with 1 minute to spare,
We've got
maybe.
minutes spare. Okay. Well, it's brilliant. I think just follow NAFMAT guidelines. So I think this example, I did see it with someone 35 going a week to India. Should they consider chikungunya? So there was an outbreak reported in India. I had a look last year. So there is an outbreak, but it listed the areas the outbreak was in. So NAFMAT recommend the vaccine at the moment if you're going into an area with an outbreak occurring or you're a long-term traveller. So if you have someone going for a week, I wouldn't class them a long-term traveller. The outbreak region in India that they were asking isn't where the outbreak's occurring. if they were going for a week and there was an outbreak occurring, I think you have a discussion with the traveller. You say, look, these are the numbers, and look at the numbers. I think, it's very person and risk trip specific. Look at the numbers in the outbreak. Is it 50 people or is it 10,000 people? Are they going to that area? What are they like with their bite avoidance? If they can't cover up with insect bites during the day, they're going to be higher risk. Are they going in monsoon season? It's not a yes and no. I think it's about having that conversation on that individual basis.
Yeah,
Yeah.
yeah. Classic grey areas in travel medicine.
Yeah. Which is what we love in Travel Health. Yeah.
All right, if we can wrap up with one very quick thing. If there's one thing you'd want every clinician to remember about travel health in 2026, what would it be? I think you probably
Uh,
already said it in a way.
I would just say, just remember, it's not all about vaccines and anti-malarials. A lot of it's around prevention, and travel health's not predictable. Things are changing all the time. We're seeing changes in regions for mosquito-borne diseases. We're seeing changes in travellers. We're seeing a lot of travellers travelling with quite complex medical conditions that have to be managed abroad. So look at your patient in front of you and the trip as an individual, not as someone going to Thailand. Look at them in particular and their trip.
I think that's a perfect message. Thank you so much,
Well,
Becky.
thank you
Gosh,
for
we've
having
covered so
me.
much. Wow. Well, good luck, everybody, in
It's been really
2026.
nice.
I hope you have some stimulating travel health consultations ahead of you, and I hope you can join us for some more sessions. Look out for them coming. This is recorded, which is terrifying, I might add, from
Yes.
both of our perspectives. It's terrifying, but it is recorded. You'll be able to access it if you got disturbed by the cat for a minute or the Amazon delivery guy came. So I think that's it. There is a feedback code. I think if perhaps somebody from it's already done. Michelle's put the link to where it'll be recorded, the YouTube channel, and also if you could do us a bit of feedback, we'd be very grateful. We can see there's some lovely feedback in the chat. Thank you so much for that. I'm glad some of you found it really interesting. We love you too, Laura. There's so many familiar names in this group. But if we could just quickly put the feedback link, is it already gone in? Oh, I'm just looking to see, and then we'll close the session once that link's in the chat. Oh, yeah, she's done it, Michelle. 1316. Yeah. Okay, if you could grab the link, thank you. And we shall sign off now. Enjoy your lunch if you've not had it yet. And thank you again, Becky.
Thank you.
Bye
All
for now.
right.
Bye,
Bye.
everyone. Bye.